move on to the practical aspect of this webinar, which will interest a lot of clinicians, a lot of doctors, because as doctors, we are prone to getting this infection. Probably the viral load is more, or many aspects to it, which we want to understand better from who else than the people who have undergone the recent, the experience themselves or in their families. The doctors we have collected here have been gracious enough to share their experience. I know it is not an easy thing to share a personal or experience in the family. The next talk will be by Dr. Kulkarni. He's a good friend of mine. He's a neurologist, and at this point, he would say that he would not go into the details of his introduction, but he will start with his talk, and maybe at some other later time, we'll talk about his personal details because he wants to keep it to a minimum. I would request Dr. Kulkarni to share his screen and start his talk. And I would like to say that he is barely recovered. Last 10 days or so, he has been convalescing after being admitted for COVID himself for about 2 weeks. Dr. Kulkarni, please share your screen and give your talk.
Yeah.
We welcome you to
Yeah, yeah.
ROS and thank you for accepting our invitation.
Yes. Thank you. Can you see my screen?
We can see you with a nice mask on. The screen will come up shortly.
Yeah, the reason I'm wearing a mask is just to emphasize that, see, if both the people, that is the person who is infected and the person who is non-infected, they wear a simple mask, there is more than 95% chance that you will not get a disease even if you are in a close contact. So this has to be emphasized. And what I see is many a times they just wear a mask, but the mask never closes the nose. It's no use. So proper way of wearing the mask and not to touch any part of the face. So in case you are forced to do that, we have to consciously make sure that we don't touch any part of the face. By chance, if we do that, our first thing is to go and wash hands. Okay, this is the first principle.
Right.
Okay, just a minute.
Yes.
Yeah, can you see?
Yeah, your screen is on. Please make it full screen, please.
Yeah, it is full screen.
Not here, but you can proceed. That's fine. You can see it nicely.
Yeah, just a minute. Let me try once more. Now, can you see? Is it full screen?
It has not yet come. Probably it will be there shortly. No slide yet.
Yes, 1 minute. Sorry for that.
Press Alt and Tab.
Now, can you?
Not yet.
No?
Yes, now full screen. Yes. Go ahead.
Okay.
Yeah, nice.
See, first of all, thank you, Dr. Mukesh and your team in the Rajkot Ophthalmology Society. So my just two principles I want to highlight is masks are very useful when worn properly by all. And I firmly believe that almost all patients can be treated successfully provided latest protocols are followed by every team member, including the patient. So this is my story. I felt tiredness and fatigue for 4 to 5 days, but it was not disabling me much. I was carrying out with my day-to-day, I was seeing my OPD clinics, everything. I used to go walking to the hospital, which is about a short distance from here. So I had no breathlessness, no cough, no diarrhea, no anosmia, no fever for 5 days. Only some tiredness. And you can't even say fatigue. I can say just some tiredness, that's all. So there was no body ache as such. So fever on the 6th day. So while I was in my clinic, I felt feverish. Then immediately went down to ER. Then my saturation was okay, my vitals are okay. But since they did the lab test and ferritin was high. So once that was high, so the swabs were taken and they didn't wait for any of the results, and immediately one dose of Plexane steroids started in the ER. With O2 just as a precautionary measure, there was no drop. I was given antivirals, lopinavir and rotinavir. I was admitted in the ward. Second day, I developed fever, no cough, no diarrhea, appetite and sleep were throughout normal in my 2 weeks hospital stay. Now received tocilizumab on day 4 as X-ray showed some worsening, and shifted to step down ICU for NIV on day 6 of admission. CT done on day 6 was suggestive of COVID and score was 12. There was mild effusion, echo heart was normal. So of these 4 days, I had persistent fever, and on 2 days, I had 4 to 6 grams of injectable paracetamol per day, despite which fever persisted. D dimer was always below 300, and hence I was given a lower dose of Plexane once a day after the first 3 to 4 days. I was shifted back to ward on day 12 and discharged on day 14. Doing well for 10 days after discharge, repeat pulmonary function test done 3 days ago, normal. So what made the difference? This is what I would like to highlight. This is not 1.4 liters, sorry, it is point number 1, 4 liters of water intake in 24 hours apart from tea, juice and IV fluids. High protein diet, paneer, eggs, soya for vegetarians twice a day. Prone lying, this is the most important thing. So I will show you the picture why prone lying is helpful. At least 90 minutes in 24 hours, even while not on NIV. Steroids have to be given for 10 days, proper dosage. Plexane for 10 days. Broad spectrum antibiotic, antiviral, the choice can vary. Vitamin C, 1000 milligram per day along with zinc, and good sleep. So these were the hallmarks of the basic principles of the treatment. If these protocols are followed, I believe that more than 90% can be successfully treated. Every member, including the patient, has to adhere to protocols. Many patients, I was told that just because they didn't drink adequate water, they went into renal failure. And once you develop such complications, it becomes very difficult. So now the key is, because I had elevated ferritin at admission, and since the next day my oxygen saturation dropped, I was probably listed in the moderate to severe category. So now it is very clear that if we follow these things, treatment can be done successfully. But the point is, everybody should be aware of these things And each clinician who's treating COVID patient has to make himself or herself up to date with the knowledge available, because things are changing rapidly. So one way is, see, we all know that more than 90% they just have some fever for 4 to 5 days and then improve on their own. The problem is some patients are missed like this, and they might have been asked to go home and then suddenly come with breathlessness and worsen. So the key is, how do we identify these patients? One simple test which many are doing is to ask the patient to walk for 3 minutes. And at the end of 3 minutes, if the saturation drops down, then these are the potential patients who may worsen. So start dexamethasone and heparin along with the others in these patients. Okay, and as said by our earlier speakers also, CT scan can give a measure of severity, but then the question is how early to do and when to repeat. I don't think there is any answer, but I feel day 3 or something, a patient has symptoms, so test CT scan combined with SpO2 measuring SpO2 after 3 minutes of walking can definitely detect high risk patients, and these patients, if tackled very well, they do extremely well. If tackled very early, do extremely well. So my repeat COVID test was twice negative 10 days after admission, which is partly due to the earlier onset of symptoms, I guess, and also antivirals should have played a role in this. See, this is, I think you need to spend some time on seeing this slide. See, this is the reason why prone position is helpful. I'm very thankful to my intensivist who was very insistent on this fact from the day I told him that I've been admitted. And he said he used to tell this to me at least 3 or 4 times per day, please sleep prone, please sleep prone. Initially, I was a bit skeptical because I never sleep prone and I used to get back pain. So he said, nothing will happen, don't worry, just put some 2 pillows under your abdomen, you will not get back pain. Listen to music, everything will be fine. So at least half an hour at one stretch, and at least 1.5 hours over 24 hours. So you can see when you are lying down prone, both the dorsal and ventral alveolus open up. Okay? So when you are lying down supine, only the ventral alveolus open up. That means there is not enough oxygenation happening. So simple, it is advisable for all of us to lie prone at least for 1.5 hours in 24 hours. And this will help in a long way. And in fact, our intensivist has saved many patients who were about to be ventilated. And because he had joined here recently, there was a lot of skepticism. And 2-3 patients, the ventilator was made ready. He put his foot down and said, though the saturation was only 60-65%, he said, just do NIV, non-invasive ventilation, prone for 7 or 10 days. And then all of them went home walking. See, once the patient is on ventilator, whatever you do, the mortality is very, very high. So the gold standard is try to avoid going in the ventilator, and these are simple measures which all of us need to follow. So I just want to conclude by saying that we can win the battle. It is not all that grim as it is painted to be. Only thing is, we all should be aware of certain small and simple steps which we need to take as clinicians as well as patients. I think now we have adequate knowledge regarding the pathology, pathophysiology, and the whole disease process. Now, unfortunately, we don't have a vaccine or a good antiviral now which will prevent. But as far as treatment concerned, I strongly believe that almost all patients can be treated successfully. So there is hope, follow all precautions, and treatment is definitely very, very, very promising. So all is well. Thank you.
Excellent, Dr. Kulkarni. for that loud and clear message. I want to reintroduce him. He's an incognito neurologist, very senior neurologist with high experience, many years of work. And he is a good friend of mine. He has taken all the trouble to delineate what we should do and what we should not from his own experience. What more can we have from a person who has recently undergone all the trouble? Thank you so much, Dr. Kulkarni. And we
Thank
appreciate
you.
your contribution, and please stay back for any further comments
Sure.
and questions which may
Sure,
arise
sure.
from other people's presentations. Right.
Sure.
We would now